When I first started in healthcare, you had this big filing cabinet that had your precautions for hepatitis, your gastric precautions, HIV precautions. So we had precautions for each disease. And it became very cumbersome, and it was hard for people to keep straight exactly why or what you did for what disease process. And we finally got smart and figured out we don't have to know what the disease is, we just have to know how it's transmitted and break that chain of transmission in order to protect the patients and our healthcare workers. So transmission-based precautions are steps that interrupt the infection cycle before the microorganism is able to spread from one person to another or even onto inanimate objects. It also determines the mode of transmission of the pathogen in order to implement the use of proper personal protective equipment. And it's based on the mode of transmission rather than the pathogen itself. So if it's a bloodborne pathogen, then it's going to be one set of precautions. If it's airborne, it's going to be a different set of precautions. It's not based on the disease. The PPE, you have to wear a fit-tested NIOSH-approved N95 or higher level respirator for respiratory protection when entering the negative air pressure room. But also, if you have to have them in a regular room because you don't have a negative air pressure room, you still have to wear the N95. The N95s, you're supposed to be fit tested when you are hired so that you know what size mask protects you. And then that fit testing is to be completed annually, and that is an OSHA requirement. When I first started doing employee health and doing the fit testing, I was amazed at how many people from year to year, their size changed. Because I thought it was really crazy to have to do it every year. But I've seen in the last 4 years why. There's a lot of people who changed the size and shape of their face. It takes less than a 2-pound weight difference to change the shape of your face. And follow standard precautions regarding the use of gloves, gowns, shoe covers, head covers, and eye covers as needed.
Okay, good question. Want to know about guidelines for smokers that are, those smokers, that happen to leave and go outside in terms of their dress and everything. Do you want to?
In our facility, our policy is if they leave the building for any reason, whether it be smoking, just go
lunch,
walking outside,
errands,
whatever, if they leave the building, when they come in, they have to change clothes.
Is a lab coat sufficient?
If they wear a lab coat over their clothing when they go outside, then they have to change the lab coat when they come in.
But the scrubs underneath would be still, I'm assuming they're in a pre-op situation or something like that. Procedural. So procedure area, put a lab coat on, go out and smoke, and then come back in.
If they're from the OR or a procedure area and they go outside, a lab coat's not sufficient.
They need to, in that case, they'll need to change it all over again.
And they're not happy about it, but many of them have cut down the number of times they go smoking.
I'm going to talk to you again about some common multi-drug resistant organisms. MDRO, AIRO, you'll hear them termed as both. Discuss the routes of transmission again. And what you guys are all actually excited to hear about is prevention measures. So I'll try to spend the most amount of time on that. So MDRO, loosely, antibiotic resistant organisms, organisms that are resistant to one or frequently multiple classes of antibiotics. So the common gram positives are going to be your MRSA and your VRE. Isolation precautions in waiting rooms. So we talked about how you don't know about a patient when they walk in the door. They could have acquired pretty much anything in the week or month since they've just talked with their surgeon. It's important to minimize crowding in your waiting rooms. The more people you have in a closed space, the 5 C's for MRSA acquisition and for other organism acquisition, definitely minimize crowding as much as possible. Your waiting room staff, whoever's greeting the patients, really should be able to do a quick and dirty assessment of the patient. So if they can see some sort of boil or active draining infection. The other thing to remember is the community respiratory viruses, a rash, if the patient clearly looks febrile. things like that, they should be able to assess very quickly, and if they don't feel the ability to impact it, they should be able to communicate that to a clinical staff member who can. Then at that point in time, pull the patient out of the crowded waiting room into one of those back exam
We're ready
rooms.
for some more questions on this whole subject. One thing I might mention is make sure when you get back to your home base, what I would recommend is that you review your policies and your procedures on how you're going to handle these kinds of patients. I am seeing an uptick in citations when we're just not following our policies, and I think we get into that sometimes when maybe this policy was written way back when and you kind of forgot about it and now you're doing something different. The most recent surveys I've been on, I'm actually seeing the surveyors take copies of the policies back with them, and they're using that in their documentation of your citations. So it makes it real easy for them to quote what you did and then, you know, why you didn't do it. And then of course the other piece of that is along those same lines, they are, once they look at your policies, they're interviewing your staff to make sure that they can, you know, speak to those policies. They love to do that as well. So I would just do a little bit of refresher.